Hi and welcome to the channel Love Obstetrics and Gynecology. In this video, I'll talk about what is menstrual history, how to diagnose the abnormal uterine bleeding as per the palm coin classification. So in this video, you learn about the menstrual history, who should know, in which patients it is necessary to take this menstrual history, how to take this history, and what is the importance of the menstrual history. So talking about who should know, whether you're a gynecologist or a practitioner or a staff nurse and you're attending a female patient, we need to know clearly about the menstrual history of the patient. In the obstetrics and gynecological department are divided into either the obstetric patients or the gynecological patients. The gynecological patient can present to you with the various complaints of discharge, infertility, or menstrual abnormalities. In all these patients, it is necessary for us to take a menstrual history of the patient. And also, the other set is the obstetric patients. It is also important in the obstetric patients because by the last menstrual period that we get to know through her menstrual history, we can calculate the gestational age. And if the periods are regular or the cycles are regular, we can say that she could have a almost corresponding LMP with the earliest, and that gestational age calculated by the LMP would be reliable in case she has a regular cycle. And also, if she has some past history of heavy menstrual bleeds, she could be anemic pre-pregnancy, which can even aggravate during this pregnancy. So it is important for both the gynecological and the obstetric patients for us to know the menstrual history about that patient to arrive at a nice diagnosis. The next we have is how to first ask at what age did the patient had menarche? Was there any history of a precocious puberty or any delayed puberty? Right. The next thing up is what was currently her last menstrual period. This will rule out any amenorrhea. The next up is the specific points that you need to ask in a menstrual history, such as in this format, right? The cycle length, duration, the regularity, the amount of blood loss she is having, and was there any associated or is there any associated dysmenorrhea. And in case she is a postmenopausal patient, you need to know about what uh, what is the duration since she is postmenopausal, and is there any postmenopausal discharge or bleeding per vagina. The next we're going to take the points that we briefly discussed about the menstrual history. So first up is cycle length. The cycle length, the normal cycle length is from 24 to 38 days. There is something known as the frequent cycles and the infrequent cycles. The frequent cycles means that the cycle length is less than 24 days. That is, she is having menstrual blood loss at either like 21 days, 20 days. She's bleeding that frequently. Then we have is infrequent cycle, which is the cycle length more than 38 days. She is having like menses after 2 months or 3 months. That is infrequent cycle. Next is the duration. Duration means for how long she had bled in that menstrual cycle. So normally we take it as up to 8 days. So anything more than 8 days is known as the prolonged duration of the cycle. Then we have is regularity. The regular cycles are considered by, like, how we consider this regularity. It is from the subtraction of the longest cycle length to the shortest cycle length, and then we see what is the difference. For example, if a patient had the shortest cycle length at 25, right, and her longest was at 30. So if I subtract this 30 from the 25, I get a 5-day difference, and which is less than this 7 which is mentioned in the criteria, right? This is less than the 7. So I consider that the patient is having a regular cycle. Then what is irregular? The irregular is when you have a duration, the subtraction of the shortest to the longest, and that makes a more than 10-day difference. That is known as the irregular cycle. Here in the regularity, you can see there is a range from the 7th to the 9th. Why is this a range? And in which age do we consider 7 and in which age do we consider 9? So for the 7 days, the 7 days we consider is from the patients between 21 to 40 years. Here what the criteria is for the 7 days. There can be a difference of 7 days or less for us to consider that she is having a regular cycle, and 9 day for females between 18 to 25 and 42 to 45. Amount of blood loss. See, any amount of blood loss that is sufficient to interfere with women's quality of life is considered as a heavy flow, right? But we can consider it as heavy, normal, or light as per the Figo. The next is we can also assess this amount of blood loss by the pictorial blood loss assessment chart, but this cannot be done feasibly in an OPD patients because we generally don't have time for that. But in case of a thesis or other procedures, we can go for this theoretical purpose also. But any amount of blood loss that interferes with women's quality of life is definitely considered as a heavy flow. The next up is the intermenstrual bleed. The intermenstrual bleed could be a cyclic bleed, like during the ovulatory period, some have a mid-cycle bleed, or they can be any random irregular pattern of intermenstrual bleed, or then also the any history of postcoital bleed or dysmenorrhea or presence of any premenstrual symptoms need to be considered. Is basically to categorize this into a differential diagnosis as per the Figo classification and to the palm coin classification, right? There can be various causes from P, polyp, adenomyosis, leiomyoma, pre-malignant or malignant lesions. These four are the structural causes. The next up is coin, that is coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, or not otherwise classified. These are not those. The above four are the structural causes, and those below written in the coin are the non-structural causes. And the AUB one by one as per the history, examination, and the investigations, how we can differentiate these. First is the polyp. Here we are talking about the endometrial polyps. The endometrial polyps can have, the presentation, and the patient may present to you with heavy menstrual bleed or the intermenstrual bleed, and this intermenstrual bleed can have any random pattern, and there could be any associated infertility. On examination, usually we cannot see a endometrial polyp. It is usually inside a vagina, or we can feel for a little bulgy uterus. Otherwise, it will be a normal examination. The investigations of choice will be definitely a transvaginal um, sonography on the first basis, and if we want to confirm our diagnosis, it will be by hysteroscopy, and hysteroscopy could be diagnostic as well as therapeutic for the patient, because in the same sitting you can even remove that endometrial polyp. Next up is adenomyosis. The adenomyosis can present as heavy menstrual bleed, which will be associated with a lot of dysmenorrhea, and the dysmenorrhea usually gets aggravated during the menses, of course, but there can be a constant pelvic pain throughout the cycle of the patient. On examination, there will be a bulky uterus that will be regular in outline and usually less than a 12-week size. And the investigations you can go for is a transvaginal sonography or an MRI. Now, as per the Figo new classification, it actually tells you that there is a criteria that you can go directly for the sonography. You do not need to directly proceed with the MRI for the diagnosis of a adenomyosis, and this is as per the 2018 guidelines. The next is leiomyoma. The leiomyoma can present as heavy menstrual bleed and dysmenorrhea, and this is in the case of we're talking about a submucosal or a intramural fibroid. In case of a subserous fibroid, that may be a asymptomatic patient, as in relation to the bleeding. There may not be any bleeding abnormalities in case of a subserosal fibroid. But if you are facing for a submucosal or let's say intramural, the patient will have some menstrual complaints, and usually it is a heavy menstrual bleed. There will be a bulky irregular uterus that can be more than 12 week size. It can be less than 12 week size, and usually the fibroids they grow large more and can be more than 12 week size. And the other important point is irregular. See, in adenomyosis it was a regular. Here you will have a irregular uterine outline. And if it is a fibroid polyp, obviously that will be visible on your per speculum examination. Again, the investigation will be same. Next we come to is M, that is pre-malignant or the malignant lesion. There will be an irregular pattern of bleeding. The patient's general physical examination, the patient's build may be malnourished, the patient may look anemic or cachexic, and then local examination, there may be a bulky uterus that has a restricted mobility, and there may be any fornixial involvement. Again, the investigations that we go for is same, the sonography and the MRI. Now let's talk about something, the other part, that is the non-structural causes. In the non-structural causes, first we have is a coagulopathy. See, in the coagulopathy, if you go for, there will be a history of heavy menstrual bleed, and that will be from since the menarche of that patient, and she could have a family history of bleeding disorders such as a von Willebrand disease or any hemophilias, or if it is something that is acquired coagulopathy, that can be in the chronic liver diseases or in the alcoholic liver diseases. So this was all about the coagulopathy. Next we have is ovulatory dysfunction. The ovulatory dysfunction, it is also an important cause of AUB. There will be an episode of amenorrhea which will be preceded by the prolonged irregular bleeding. Episode of amenorrhea followed by prolonged irregular bleeding. Now this amenorrhea actually means is there was an estrogen presence, but there was no progesterone. There was no progesterone. The estrogen was present, and finally estrogen keeps on building up the endometrium that does not get a progesterone support, and when that progesterone support is not available, there will be a breakthrough bleed. So this is the physiology of this ovulatory dysfunction. This ovulatory dysfunction can have various causes such as in eating disorders, anorexia nervosa, or there is excessive physical exercise, there is thyroid disorder, or some acquired stress, or alcoholic disorders, or primary ovarian failure. Any of those causes can be present in an ovulatory dysfunction. Now these were all the pathological ones, but there are also the normal physiological, like the patient during the puberty, early puberty can have ovulatory dysfunction, right? In the perimenopausal can have, in the during the lactational period. Those are the physiological causes where the ovulatory dysfunction and AUB can be present. The next up is are endometrial causes. The endometrial here means, see, we already considered endometrial polyp in the polyp, and endometrial hyperplasia is also in the pre-malignant lesion. Here we are talking about endometrial in endometritis. and that will cause heavy menstrual bleed. The iatrogenic includes is any anticoagulants if patient is taking, right, anticoagulants, or while being on oral contraceptives she is having any breakthrough bleed, or during any of the progesterones there can be initial irregular bleeding cycles. So those are the iatrogenic causes. Uh, this is as per the new FIGO classification. Firstly, these anticoagulant drugs, they were included under the coagulation disorder, but now currently these are considered under the iatrogenic. And same for these oral contraceptives also, because they cause anovulation and all the bleeding. So that anovulation, it is not included under the ovulatory disorder. It is now considered under the iatrogenic causes. And something they're also known as not otherwise classified. It is also changed as per the new FIGO. It is not the yet. So we do not use the term yet these days. It is not otherwise classified. And it includes AV malformations, or if there is a prior cesarean scar, on that cesarean scar there is presence of any isthmol or niche, and those are the causes of AUB. We consider that under not otherwise classified. Let's take an example. I have a patient that is Mrs. A. She is aged 45 years and has a complaint of heavy menstrual bleed. In this case, I had a patient that was aged 45, which means she is in somewhat perimenopausal age and she has heavy menstrual bleed since 1 year. See, this is quite troublesome for her because she is having it since 1 year. Now, her prior menstrual history, she had menarche at the age of 14, which is good. That means she had it at an appropriate age. Next is prior cycles were regular, which means there was no history of any coagulation disorder right from her menarche. There was associated slight dysmenorrhea. See, slight dysmenorrhea means the cycles were ovulatory before, and at present she has around 10 to 15 days flow. This flow is definitely increased over here. Why am I saying this? Because it is more than 8 days and associated with passage of clots. The passage of clots also signify that there is increased or heavy menstrual flow or is increased flow. She is having 3 to 4 full pad soak. You need to ask about the patient how many pads she changed, but she might be changing 6 to 7 pads in a day. That 6 to 7 pads does not mean that she is heavy menstrual bleeding. She might be changing it every 2 or 3 hourly on her hygienic basis, which on which there might have been just a spotting or just a superficial soakage. It is very important that you ask the patient were they fully soaked or just partially soaked. The next up is my cycle length. Her cycle length is of 20 to 22 days. The cycle length is less than 24 days, right? 24 days means she is having a frequent cycles, the frequent cycles. And why am I saying the next is regular? See, the regular here means that the regular is from the shortest length minus the longest length. So 20 to 22 days means only there was a difference of 2 days, which is less than the, in case of here, it is 45 age. The 45 age, the parameter that we need to consider is 9 days. So here I have a difference of only 2 days. So the cycles were regular. And it is associated with dysmenorrhea on the days of heavy flow. Prior obstetric history is para 2, live 2, and those were the vaginal deliveries. Her history of hypertension is there. On general physical examination, she is obese. See, these two are the high risk factors for a pre-malignant lesion. And on bimanual pelvic examination, it was 8 to 10 week size uterus, which is regular and mobile, and the fornices are free. Now here there are many points that are mentioned. First was, just talking about just the positive points in her menstrual history. Her flow is increased, her, as per this also, flow is increased, the cycle length is decreased, the cycles are regular, the cycles are frequent, and there is dysmenorrhea, and she is a high risk factor. And on examination you can possibly say that there is some structural cause related to it. You can definitely say that there is some structural cause related to it. So I am going to have now some differential diagnosis based on my history. The differential diagnosis, here we can write it in the tabulated form, as you can see. Can I say that there is polyp? There can be presence of any endometrial polyp, yes. Though there is the bulkiness of the uterus usually suggests that there could be adenomyosis or leiomyoma, and these adenomyosis, leiomyoma, polyp, these all are under the effect of estrogen, so they all can coexist together also. And I cannot exclude a pre-malignant or a malignant lesion in such a aged woman, right? Beyond the age of 40. If a patient present to me with AUB, I have to take a histopathology out of her for excluding out this pre-malignant or a malignant lesion, right? So I have put all these under the query of my differential diagnosis, that any of these could be a cause for her AUB. Next up is coagulopathy. See, there was no history as such, I could say, of a coagulation disorder, because at the time of her menarche she was fine, she had regular histories prior. Now ovulatory dysfunction. Well, ovulatory dysfunction could have been a cause of her bleeding at present also, because ovulatory dysfunction is present in cases of a perimenopausal woman. But here I would like to say that there could be more probably a chance of a structural cause than an ovulatory dysfunction as such, because the size of the uterus is more. Next is endometrial. See, there was no tenderness or fornicial mass felt, or there was no, she did not give me any history of a PID before. So I cannot say that it is a endometrial cause. Iatrogenic, she did not give me any history of any drug intake that could have caused this complaint. And not otherwise classified, she did not had any history of any intrauterine manipulations, we can say. No history of any cesareans, no history of any dilatation curettage, so that we could have any AV malformations or any scar site problems, right? So these are under the category of a no. Mystery. So I would like to get her investigated, the blood investigations as they would go, CBC, triple H, her basic investigations, fasting, blood sugar levels, ESR levels, thyroid profile, all that of a gynecological patient that I'd like to do. Those will be my blood investigations. The next, obviously, the pap smear is conducted in this patient, or any patient that you are examining in the gynecological OPD, because it is the best time for her cervical screening also. Next we come up is imaging. The imaging, transvaginal sonography usually rules out a lot of structural causes. For example, the polyp, adenomyosis and leiomyoma, these can get differentiated in the transvaginal sonography. And if you want to further proceed with the confirmatory diagnosis, or you are not that sure on a vaginal sonography, you can go for an MRI. But transvaginal sonography is the first investigation that you will like to get this patient investigated on. So from these I get differentiated to that she has a leiomyoma on her transvaginal sonography. It shows me that there is a leiomyoma. And the further I like to do is a endometrial sampling of this patient. You can do it by a endometrial pipple. That is just an office procedure, no anesthesia required, and just it is also comfortable for the patient also. Or you can go for a dilatation and curettage. That will obviously require some investigations and the pre-anesthetic checkup, and also requirement of anesthesia and hospital admission. But in any case, you can choose any of those methods, but a histopathology is definitely required to rule out the endometrial hyperplasia. So in this case, I get no endometrial hyperplasia. So I've solved the mystery that the patient is having abnormal uterine bleeding because of leiomyoma. Here you can see what I had queries. I had query of polyp, adenomyosis, leiomyoma and a premalignant lesion, and I have ruled out all those. Specifically, you can see this all here my queries got converted into either a yes or a no. This is what is the benefit of this table. You do not miss out on anything. You take a cause one by one and rule out those things that you think the patient might be having. So, the video, please subscribe and share the channel Love Obstetrics and Gynecology.